Hello, good evening. So today is the session 3 of our marathon last minute revision for MRCP Part 2. I'm Dr. Rishit Harbada. I'm one of the mentors with Study Medic. And the plan is that today we are going to discuss about two very important topics from the point of view of your exams. The first topic is gastroenterology, and the second topic is infectious diseases. So in the next 2 hours, we'll try and give 1 hour each to each of the topics. And in the last 10 minutes, we'll give you some important MRCP pearls, which may help you to solve certain questions. So without wasting much time, I will start the first topic of today, which is gastroenterology. Okay. So the first topic is about gastroenterology. So the roadmap will be that the gastroenterology hepatology section has around 19 questions from our exam, which form 9.5% of the total weightage of the exam. And the infectious disease also has around 19 questions. So together, these two topics cover 38 or approximately equal to 19% of your exam from MRCP Part 2. Now, the first topic is gastroenterology or hepatology. And as I said, that it has approximately 19 questions. It's not fixed. It can be plus minus 2. You can have the questions. So the roadmap or the approach today will be that first we will try and interpret LFT patterns. So we cannot cover everything in the next 1 hour, but important exam related questions will be covered from here and the important questions will be covered. So the first is that the LFT patterns will be seen. How on the basis of LFT we can differentiate the patients into hepatocellular versus cholestatic versus isolated bilirubin. Secondly, the GI bleeding, whether it's an upper GI bleeding, lower GI bleeding, and how do we approach this patient. Third is decompensated cirrhosis, and the various complications of cirrhosis, including ascites, variceal bleed, hepatorenal syndrome. Fourth, we'll talk about inflammatory bowel disease, in which we will cover Crohn's and ulcerative colitis. And lastly, we'll cover some important topics like esophagus, pancreatitis, malabsorptions, like other things which we will cover. So the first one is that LFTs, we all know that liver function tests, when we are given a problem, we are given certain values, and based upon those values, we have to interpret whether these liver function tests, whether the patient has a problem, and if the patient has a problem, what is the kind of problem which is there. So whenever you actually see a liver function test, you will see bilirubin. In bilirubin, you will see two important components. One is a direct bilirubin and one is an indirect bilirubin. You will see what is called as the liver enzymes, which is SGOT, SGPT, or AST, ALT. And you will see alkaline phosphatase, and you will see GGTP, that is gamma glutamine transferase. And lastly, you will see serum proteins, and you will see something called as albumin. So this together forms the liver function analysis. So whenever you are brought to a liver function test, the first thing you are always going to see is whether there is increase in the bilirubin. Okay, so if the bilirubin is increased and if it is more than 1, then it means that there is some problem in the liver. Secondly, you will see the liver enzymes. So let us talk about the liver enzymes. The first liver enzyme that we are having is ALT. Now, ALT is a very, very specific enzyme, which is usually a cytosolic enzyme, which is actually there. And this ALT is actually very specific for the liver. Okay, now ALT is actually going to be increased whenever there is going to be a parenchymal damage, which we are going to see. The second is AST, which is not only specific to the liver, but it can be formed in the muscles, it can be formed in the heart and other organs. And as a result, the AST is actually not liver specific. Okay, it's a mitochondrial enzyme. So if the ALT is more elevated as compared to the AST, it means that there is definitely a liver problem. And this can indicate either a viral hepatitis, it can indicate an autoimmune hepatitis, certain drugs, it can have ischemia, and non-alcoholic fatty liver disease. Now, normally, as I said, that ALT is much more specific for hepatitis, and if the ALT is much more increased as compared to AST, always think about these diagnoses, that is viral hepatitis, autoimmune hepatitis, drugs, or NAFLD. But in the case of alcoholic hepatitis, the reverse is true. So always remember that If the AST is enlarged the AST is elevated much more as compared to the ALT, then always think about alcoholic hepatitis. So you may get a question where a young male is present and he is presenting with a high amount of ALT. So if the ALT is actually increased, then this ALT elevation is actually going to be, AST elevation. If it is more than 1000 and the AST is to ALT ratio is more than 2, then always think in the form of alcoholic hepatitis. So you may be getting this question where you may be asked that if the AST is elevated as compared to the ALT, then it is actually going to be an alcoholic liver disease. Okay. The second one is, so suppose if you have analyzed, then you have seen that there is a parenchymal injury which is there. And as a result, the AS, SGOT, SGPT or AST, ALT are going to be elevated. Now, suppose in the cirrhosis, because it is already damaged, sometimes the liver enzymes are not elevated. Okay, so even if the liver enzymes are not elevated, it doesn't mean that there is no problem in the liver. Okay, so in cirrhosis, etc., because there is not much parenchyma left, as a result, the liver enzymes may not be elevated. The second one, so after you go to the AST, ALT, and you see that the transaminitis or the liver enzymes are enlarged, increase. The second is you go towards to see whether there is any obstruction which is there. So there are two important enzymes for obstruction. One of them is the ALP, that is alkaline phosphatase, and the second one is GGTP. Now, alkaline phosphatase, just like AST, is not specific. It can be secreted by the liver, it can be secreted by the placenta, and it can be secreted by the bone. So, if the ALP is elevated, but the GGTP, which is very, very specific to the liver, if both are elevated, always think in direction of the liver. Okay. If only ALP is elevated, but GGTP is normal, think in terms of bone disease, like Pancreas disease. Okay. So as I said that the GGTP is much more specific for liver patients, whereas ALP is not very specific. It can be elevated in bone disease. It can be elevated. It can come from the placenta, or it can also come in the form of the bones or this thing. And as I said that if the liver enzymes are actually, if the ALP and GGTP are increased, then you always think in terms of obstruction in the liver, which can actually be coming from the CBD stone, cholangitis, pancreatic cancer, cholangiocarcinoma, etc. Whereas normal GGTP with raised ALP, always think of bone diseases like CKD, NBD, that is chronic kidney disease, metabolic bone disease, Patch's disease, bone metastasis, etc. Whereas only GGTP and without ALP is again not very, very sensitive. So for cholestasis, you have to do both. So if ALP and GGTP are both dominant, always think in terms of obstruction, which can be primary biliary cirrhosis, which is an autoimmune hepatitis, or drug cholestasis. Now, synthetic function of the liver, the third category of tests. So the third category of test is how well the liver is functioning. So if the albumin is actually going low, it means that the patient is actually going to have liver damage. But albumin's half-life is more than 20 days, and hence it may not be lower in acute liver failure. The second test for the synthetic function of the liver is the prothrombin time. So we all know that the liver produces 4 clotting factors, factor 2, 7, 9, and 10. They are secreted by the liver. And as a result, they get damaged. Whenever the liver gets damaged early or when it's a liver failure, the INR actually starts going up. So the INR is going to give a true reflection in acute liver failure. Whereas in chronic liver failure, the albumin is going to be low and the INR is going to be. The last test is going to be the bilirubin. The bilirubin normally ranges from 0.1 to 1. And we all know that the direct bilirubin and indirect bilirubin are the 2 types of bilirubin. So when we talk about jaundice, I'll tell you more that the unconjugated bilirubin is the one which is not bound, whereas the conjugated bilirubin undergoes glucuronidation in the liver, and it actually forms the bilirubin. So that is how the bilirubin is going to be affected. Now, in bilirubin, if the unconjugated fraction is going to be increased, it means that there is a problem before the bilirubin enters the liver. So it's a pre-hepatic jaundice, and it is usually seen in hemolysis, which is a most common reason. So in that, the unconjugated bilirubin is increased, and there are two congenital diseases, that is Gilbert syndrome and Crigler-Najjar. For your MRCP, concentrate more on Gilbert syndrome, where the patient may have unconjugated hyperbilirubinemia. It's a benign problem, but whenever the patient is fasting or is ill, the bilirubin may go up. Okay? As I already told you that AST and ALT with the ratio is more than 2, it is causative of alcoholic liver disease, because alcohol damages the mitochondrial AST, whereas ALTs are affected chiefly from the cytosolic. Okay, so that is why AST is more affected because of alcohol. Normally, AST is the most predominant, but if you get a question where AST is elevated, always think about the liver disease. So whenever you are interpreting the liver function test, always see whether the ALT or AST are elevated. So you will think in terms of hepatocellular. If the GGTP and ALP is elevated, think in terms of cholestatic. If the albumin is low and PPINR is high, think in terms of synthetic function. And that is how we are going to approach this. So this is a very simple flow chart. We are going to see that if the ALT is going to be increased along with only the liver enzymes, but the ALP is normal, then this is usually going to be hepatocellular. And if the alkaline phosphatase and GGTPs are going to be increased, it's going to be a suggestive of obstruction, primary biliary cirrhosis, or drugs. If only the ALP is normal and the liver enzymes are normal, you will only have isolated hyperbilirubinemia, then it's going to be Gilbert's or other diseases. And lastly, you may only have both, where the ALP and the AST or ALT, the alkaline phosphatase are going to be increased. So ALT, if it's dominant, think about hepatocellular, and if it's ALP dominant, think about cholestatic. Okay, and if it is ALP is dominant, always confirm it with GGTP, because only ALP is not specific for the liver. Okay, so this is about how you interpret the liver function test. The second is the jaundice. So jaundice, which will mean is that whenever the bilirubin in the blood increases up to a particular level, it is called as jaundice. And we all know that for the jaundice to actually come in the, to be visible clinically, the bilirubin level actually has to be between 30 to 50 as per the standard SI guidelines. And as per the Indian, this should be more than 2.3. So if the bilirubin is going to be increased by more than 2.3, then it is called as the jaundice. And jaundice actually is the yellowish discoloration of the skin, sclera, and the mucous membrane, because the bilirubin is going to be much more increased. And as I said, that if the bilirubin is increased about 35 to 50, it is hyperbilirubinemia or jaundice. We all know that the jaundice appears first in the sclera because it has very high affinity for elastin. And as a result, it appears first in the sclera and then it appears in the other organs. Now, moving further, we all know that bilirubin is produced by the senescent or the old RBCs. So the old RBCs actually get damaged. And after the old RBCs are damaged, these RBCs are going to be broken down and they are going to be forming into heme. This heme gets converted to biliverdin, and this biliverdin then goes and forms the unconjugated bilirubin. Okay, so this is how the unconjugated bilirubin is formed from the blood. So whenever there is a hemolysis, we are only going to see unconjugated bilirubin. Now, after this unconjugated bilirubin, this bilirubin, which is unconjugated, goes into the liver, and then it is actually going to undergo glucuronidization with the help of UDP glucuronyl transferase. And this is going to form the conjugated bilirubin. Now, unconjugated bilirubin is lipid soluble, it is albumin bound, and as a result, it is not present in the urine. So, if the patient has hemolytic anemia, you will not see the presence of bilirubin in the urine. But direct bilirubin is not albumin bound, and it is actually water soluble, and it is actually detected in the urine because it is water soluble. Okay, now this bilirubin then goes into the intestine, then it forms stercobilin, and then it is excreted in the form of stercobilin. Whatever bilirubin is left can get reabsorbed and can be excreted in the urine in the form of urinary urobilinogen. Now, the jaundice is divided into three parts. First is prehepatic jaundice. We all know that prehepatic jaundice means that it is happening before the bilirubin enters the liver, and the most it is associated with increase in the unconjugated fraction of the bilirubin. So urine will be normal, the LDH will be increased, the plasma will show the presence of cystocytes because of hemoglobin, the haptoglobin will be low, and the urine will be normal. It will not show the presence of bilirubin. The common causes are hemolysis, for example, G6PD deficiency, presence of malaria, thrombotic thrombocytopenic purpura. All this can actually cause this problem. The second is the hepatic one. In here, the problem is in the hepatocytes. So the hepatocytes are going to be affected, and because of affection of the hepatocytes, you are going to see the presence of bilirubin. Here, it is going to be associated with elevation of the bilirubin, and the direct fraction is going to be increased more as compared to the indirect fraction. Also, the liver enzymes are going to be increased because of the damage to the hepatocytes. And in few cases, you're also going to see that this thing is also going to be elevated. Okay. Now, this is going to happen because there is a failure of the cells. There is a problem in excretion, conjugation, and cell injury, and there is hyperbilirubinemia, which is going to happen. The causes we all know are very, very common. We all know viral hepatitis, autoimmune hepatitis, primary sclerosing cholangitis, Wilson's disease, etc., which will be studied with all the main causes of hepatic jaundice. The most common symptoms patients will actually have of hepatic jaundice are they will have weakness, malaise, anorexia. They will have right upper quadrant pain where the liver is, and they may have a tender hepatomegaly. Third is post-hepatic jaundice. So after the bilirubin exits the liver and in the pores, if it gets blocked anywhere, then it is a post-hepatic type of jaundice. Here the conjugated bilirubin is going to be increased more. The bile cannot reach the intestine, and hence the stercobilin is not excreted. So the patients produce what is called as a pale stool. Most of it is excreted in the urine because it's conjugated and it's water soluble. So they will have a dark colored urine. And because there is obstruction, the ALT and GGTP will be increased. So this is how we are going to differentiate the jaundice in most of the cases. Now, obviously, if you have a patient of jaundice, you will do the LFT, confirm it. You will see whether there is any signs of hepatic injury by doing PGINR and this thing. And then you will do an imaging. Preferably, you will do an ultrasound to see if there is any dark dilatation, like intrahepatic biliary radicals, whether they are enlarged or they are enlarged or not. And you will see the MRCP, and then you will, if there is an obstruction, then you will actually do an MRCP, which is diagnostic. And if there is a gallstone or something, or if there is a cancer which is sitting over there and blocking, you will do an ERCP, which is going to be therapeutic. Okay, now if a patient actually presents with cholangitis, what is cholangitis? It's an inflammation which is there of the bile duct. In that situation, the patients will present with high-grade fever, chills, jaundice, and right upper quadrant pain, which is the Charcot's triad. In this situation, the treatment is going to be antibiotics, and you have to do the biliary drainage. So always remember that in the MRCP, if you are going to get a question, if there is a patient of jaundice, try and differentiate into the three types based upon the bilirubin, urine findings, stool, and you will be given some example. So if you are getting an example, if the patient is having high-grade fever, confusion, high bilirubin, tender hepatomegaly, and jaundice, always think about Charcot's triad, Mucin cholangitis. And if along with the Charcot's triad, you are having two other symptoms. One is hypotension, patient is short, and confusion, then it's a Reynolds pentad, and that is usually seen in severe cholangitis, and it requires urgent biliary decompression, because cholangitis, if it worsens, it can actually affect the patient and the patient can actually die. So again, to recapitulate, jaundice, pre-hepatic, hepatic, and post-hepatic. Pre-hepatic is hemolysis, unconjugated is increased. Hepatic, seen in hepatitis, cirrhosis, drugs. Now the liver enzymes are going to be elevated and the bilirubin is going to be mixed. And post-hepatic is usually obstruction, where the ALP is increased, the stool will be pale, and the urine will actually be the dark-colored urine. Now, if the patient actually has a painless urine, then, painless jaundice, and a palpable gallbladder. So if you have a patient, you may get an MRCP question where the patient is actually presenting with a painless jaundice, and when you palpate it, when you put your hand on the upper right quadrant and it's palpable, it is actually called as Voiser's sign, and is suggestive of pancreatic head cancer. So any question in the MRCP if you get, and it is showing that a painless jaundice along with upper quadrant palpable gallbladder, think about pancreatic head cancer unless proven otherwise. So the pearl is, as I said, that if the patient has pale colored stools with dark color loop in about obstruction or post-hepatic jaundice. So we'll take the first question. You can type your answers in the chat box. There are 68-year-old male presents with a progressive painless jaundice. He has pain weight loss and he also has pale stools. Bilirubin and alkaline phosphatase are markedly elevated and the examination reveals a non-tender palpable gallbladder. So there are important highlights which are given over here. Patient has painless jaundice, pale stools, weight loss, and non-tender palpable gallbladder. So what will be the answer over here? You can actually type in your answers in the chat box. So we can actually know. Yeah. So you're correct. So the correct answer here is a pancreatic head carcinoma. So unless proven otherwise, if the patient has a painless jaundice and a palpable gallbladder, it is always suggesting of a pancreatic head cancer. And as I said, it's called as a Courvoisier's law. The treatment is you are going to do an imaging with a CT MRCP and you will refer to a specialist, so the patient will need the testing. The second important topic from your MRCP point of view is the acute GI bleeding. So in the case of acute GI bleeding, you are going to have whether the bleeding is above, if you have the GI bleeding means it can be in the form of hematemesis where the patient may actually cough out blood, or the blood may come out to the lower part, that is the patient may have melena or hematochezia or fresh PR bleeding. So whenever you have a PR bleeding, always keep it in your mind that the PR bleeding is of two types. One is above the ligament of Treats, that is called as upper GI bleeding, and second is below the ligament of Treats, which is called as the lower GI bleeding. So if the bleeding is above the upper ligament of Treats, it is upper GI bleeding, and if it's below that, it is actually called as the lower GI bleeding. Now normally, you will not be asked questions like what is causing the bleeding or why the bleeding is happening, etc. The question will be that normally what will be the management of this patient. For example, a 62-year-old male has presented with hematemesis melena. He's having tachycardia, BP is only 90/60. What is your first step? And you will be given two questions which are very, very confusing. One is whether you will do an endoscopy urgently or whether you will resuscitate this patient first. So in this situation, it is always going to be that you have to resuscitate the patient first. But as I said, I'll just quickly go. So acute GI bleeding will present anywhere. If it's present above the ligament of Treats, it's called upper GI bleeding. And common causes are gastric ulcer, peptic ulcer, esophageal varices, gastritis, duodenitis, Mallory-Weiss syndrome, or a Delafield lesion, or the cave which may be present. Lower GI bleeding can present as angiodysplasia, CA rectum, inflammatory bowel disease, colorectal cancer, hemorrhoids, or radiation cystitis. So if the patient actually has hematemesis, it is going to be upper GI bleed. Melena, again upper GI bleed, but can occur with a small bleeding. And if the patient has a fresh PR bleeding or hematochezia, it is usually going to be a lower GI bleed, which is going to be present. Okay. So if hematemesis is present in melena, always think about upper GI bleeding, and fresh PR bleeding may actually be the lower GI bleeding. So whenever you have a patient who is having a GI bleeding, you have to resuscitate the patient first, and the resuscitation involves putting two IV lines, two large bore IV cannulas is very, very important, and you follow the ABCDE. That is, you have to protect the airway, you have to do the breathing, you have to affect the circulation. You will put two large bore needles for GI14 and 16G. You will actually take the blood, send it for cross-matching. You will see that D is for GCS, and A is you will see for the cause that why this patient is having. And if the patient is having significant bleeding, you will actually give the patient blood. You will correct the coagulopathy, as well as you will also think about targeting the cause, which is very, very important in most of those cases. So IV fluids are going to be the most important. If the hemoglobin is less than 7, you have to transfuse the patients immediately, or if there is hemodynamic instability. Normally, you are going to score them based upon two types of scores. One is the Glasgow Blatchford scoring, which is very, very important. It is done before endoscopy, and it is going to predict whether this patient will need blood transfusion and endoscopic therapy. If the Glasgow Blatchford score is less than 1 or 0 to 1, it means that patient is stable. You can manage it on home or outpatient. And if it's more than 2 or 2, then you are going to need inpatient treatment. Whereas the second one is the Rockfall score is usually after endoscopy. And here you are actually going to see whether this patient is going to need treatment or patient is going to have rebleeding. So remember that Rockfall is after endoscopy to see if there is rebleeding, and Blatchford Glasgow is pre-endoscopy, which is going to show that the patient is actually going to have or is going to need the endoscopy. Okay, or can be managed on outpatient. So you have to actually do this. You have to give the patient balanced crystalloids. You give them blood. If hemoglobin is less than 7, you correct it. And if the patient has coagulopathy, you reverse the coagulation. And you are actually going to see. Now, suppose if the patient has non-variceal bleeding, you will do the endoscopy after stabilization. And if the patient only has gastritis, gastric ulcers, etc., you are going to transfer this patient. You are only going to give PPIs. If the patient has cirrhosis and has esophageal varices, in this situation, you are going to give the patient terlipressin, which is very, very important, and prophylactic antibiotics to prevent SBP before OGD-scopy, and then you are going to do something called as band ligation. So this is about upper GI bleeding. If the patient actually comes with a lower GI bleeding, you are actually going to do a CT angiography or colonoscopy after resuscitation, and you are going to treat the cause. So if it's peptic ulcer, you give PPIs. If it is variceal bleeding, you are actually going to do the endoscopy, but before that, you have to do terlipressin and prophylactic antibiotics to prevent SVP, and then you do the band ligation. And lower ones, you will actually do the CT angiography or colonoscopy. So if the patient is actually having upper GI bleeding, you do a scopy. If not detected, you do a CT angiography. And if it also fails, you do a surgery. Whereas in lower, you are first going to do a colonoscopy, then CT, and then you're going to do an embolization. Okay, so always remember the 2-3 questions, whether there is going to be any, you have to do the resuscitation, which is very, very important in this situation. Okay. Yeah. So as I said, acute GI bleed, always resuscitate. If it's upper, like hematemesis, melena, you treat it with, you do a Blatchford scoring to before endoscopy, treat with terlipressin antibiotics. Lower, you do a fresh PR bleeding like hepatic chasia, CT angiography, colonoscopy. Okay. So next question is a known cirrhotic presents with a large volume hematemesis. So here you are having hematemesis. So hematemesis melena, upper GI bleeding, patient is cirrhotic. BP is low, heart rate is 118. After fluids and cross-match, so they have already resuscitated the patient. The most next steps before endoscopy are, so before endoscopy, you have to reduce the bleeding. That can be done by giving terlipressin and by giving prophylactic antibiotics. Okay, so correct answer here is B, because terlipressin, midodrine, octreotide will help to cause the splanchnic vasoconstriction, and antibiotics here will help to prevent SBP. And PPIs can be given, but they will not be help. They will be helpful in non-variceal bleed. And a balloon tube, if everything fails and the patient is becoming bad, then only you will do a balloon tube as a last measure. The next topic is cirrhosis, which is also very, very important from the point of view of your examination. So in the case of cirrhosis, you are actually going to have, So cirrhosis, you are going to have this thing. So we all know that cirrhosis is an illness where the liver parenchyma is actually going to get affected. And in the case of cirrhosis, you are actually the liver is going to be affected in the case of cirrhosis, and we all know that it is going to cause something called as a hepatic fibrosis. So it is a disease in which the liver is going to undergo hepatic fibrosis, along with the case of regenerative nodules which are going to be formed. And the architecture of the liver is actually going to get distorted. So if the patient actually presents, or the cirrhosis definition is going to be that there is going to be distortion of liver architecture, along with hepatic fibrosis and regenerative nodules which are going to be present. And we all know that the causes of cirrhosis are very, very common. The most common are two. One is alcoholic cirrhosis, and second is non-alcoholic steatohepatitis, which is going to cause into NASH or non-alcoholic fatty liver disease. Other rare causes are viral hepatitis, which ones usually B and C. You are having autoimmune illnesses in the form of autoimmune hepatitis, primary sclerosing cholangitis, primary biliary cirrhosis. hemochromatosis, Wilson's, etc., which are very, very common, which are the common causes of cirrhosis. So whenever there is a cirrhosis, there's a liver injury. As a protective mechanism, it undergoes fibrosis. The fibrosis then causes regenerative nodules. Regenerative nodules then forms the portal hypertension. Portal hypertension causes reduction in hepatocyte function, and then the patient gets decompensated. So normally in cirrhosis, there are two types. One is compensated cirrhosis and one is decompensated cirrhosis. In compensated cirrhosis, patients are usually stable, don't have much symptoms, and they will only have abnormal LFTs, splenomegaly, mild thrombocytopenia, mild anemia, and they have some ascites or jaundice or hepatorenal syndrome, etc., which may be going in the case of decompensated. So if the body is not able to compensate and the patient starts developing significant fluid overload, fetal edema, ascites, portal hypertension, portal gastric bleeding, or hepatorenal syndrome or hepatic encephalopathy, it is considered to be the chronic, it is considered to be the decompensated liver cirrhosis. We all know that the liver cirrhosis will have classical symptoms, so the patient will be emaciated, will have significant weakness, confusion, etc. And the signs we all know that you will see spider nevi, gynecomastia, testicular atrophy, clumping, uterus contracture, etc. will be commonly seen. What are the complications that you will see? Because of portal hypertension, you will see massive ascites, you will see captive medusae around the umbilicus. You will also see esophageal varices, ascites, etc., which are very, very common. What are the imaging which we are going to see? Imaging is going to be, you are going to see the ultrasound, which will show whether the liver is shrunken. The caudate lobe may be enlarged. You will see splenomegaly. The portal vein diameter is going to be more than 31, more than 10. Then it is a ratio of portal hypertension. And you are also going to do a transient liver elastography, which is called as a fibroscan, which will help you detect what stage of fibrosis is there. Okay. With that, we are actually going to do this thing. Now, we all know that one of the most common complications of cirrhosis is ascites. So ascites, if you have any patient who is having ascites, it has to be tapped, which is very, very important. Ascites, we all know, is the accumulation of fluid in the abdomen. So any patient who has a new ascites, who has fever, who has pain, who has hepatic encephalopathy, who has a worsening renal function, you should always tap this ascites. And when you tap this ascites, you are going to see what is there in that. So what are you going to assess? One, you are going to assess the routine test. You're going to see how many cells are there. You're going to see the cytology, some culture, if there is infection. And you're going to see the ADA, that is tuberculosis. And something which is very, very important, which is called as SAG, that is serum ascitic albumin gradient, which is going to be measured. So if the cells are more than 250, it is suggestive of infection, which is called as SBP. So always remember, if the neutrophils are more than 250, it is suggestive of SBP. And you have to treat this with the case of antibiotics. And the albumin you are going to compare with the serum. So it is called as SAG, that is serum ascitic albumin gradient, where you are going to actually minus the ascitic albumin, serum albumin, and the ascitic albumin, and you are going to divide it and you are going to see the ratio. So if the SAG is going to be more than 1.1, it is going to be it is more than 11, then it is going to be suggestive of portal hypertension seen in cirrhosis or heart failure or Budd-Chiari syndrome. And if the SAG is less than 11, it is because of malignancy, pancreatitis, tuberculosis. Third is, we all know that hepatic encephalopathy is one of the most common complications of cirrhosis. Usually a patient who has not passed through, who has had GI bleeding, who has not been taking medications, has low potassium. All this will precipitate encephalopathy. Encephalopathy, the patient will present with increased drowsiness, will have altered sensorium, will have altered speech, will have the presence of flaps. So if this is the person, we may actually start having flapping. These are the signs of hepatic encephalopathy or change in handwriting. If the patient presents with hepatic encephalopathy, you have to identify the precipitant, whether the patient has had GI bleeding, has taken excessive diuretics, is having infection or constipation. To treat the precipitant, you give the patient lactulose. At least 2 to 3 soft stools should be passed per day, and rifaximin. Rifaximin is a local antibiotic which helps to prevent or helps to reduce the risk of spontaneous bacterial peritonitis. The next is hepatorenal syndrome. So hepatorenal syndrome is a functional renal affection which happens in patients with cirrhosis because there is hepatic vasodilatation. So there is a renal vasoconstriction. It is having a very, very poor prognosis and patients usually die within 6 months of diagnosis. The treatment of hepatorenal syndrome is going to be terlipressin and albumin. And your surveillance of these patients is very, very important by doing the screening, of cirrhosis. You do at least 6 monthly sonography to see if there is any tumor mass. And you do ASP, alpha fetoprotein if it's increased. And you do a variceal staining by doing an endoscopy. So any patient who presents with decompensation in the form of ascites or encephalopathy or HRS, always rule out a spontaneous bacterial peritonitis, which is very, very important. So these are very, very important pearls which you should know for the cirrhosis. So cirrhosis, if there is decompensation, you will see whether there is a variceal bleed or not. If there is a variceal bleed, you treat it with antibiotics, terlipressin, and ochdiscopy. If there is ascites or SBP, you are going to see whether that more than 250 neutrophils are present or not, and you are going to treat it with antibiotics and albumin. Encephalopathy, if the patient is having, you are going to correct the cause, the trigger, and treat with lactulose and rifaximin. And if there is a hepatorenal syndrome, you are going to treat it with terlipressin, albumin, and has a poor prognosis. For spontaneous bacterial peritonitis, albumin is the treatment of choice along with the cefotaxime. So when you give the antibiotics, it actually reduces the risk of what is called as the spontaneous bacteria. It reduces the risk of translocation. And if you give albumin, it reduces the risk of the hepatorenal syndrome. So next is very, very important is this question. So you can read it. So a cirrhotic patient has presented with ascites, develops abdominal pain and fever. And here the ascitic tapping is done and it shows 480 neutrophils. So the cells are more than 450 and the patient is hemodynamically stable. So what are you going to do over here? Here you are going to repeat the tap in 48 hours. You're going to give cefotaxime plus albumin, or you are going to give oral ciprofloxacin. You're going to give therapeutic paracentesis, or you're going to give lactulose. So here the patient is having more than 480 neutrophils, which is suggestive of what is called as a SBP. So here the treatment will be IV antibiotics, cefotaxime and albumin, because it will reduce the risk of the hepatorenal syndrome. Do not wait for cultures. That is very, very important over here, which is extremely essential. So ascites, as I already discussed previously, that if the SARC is more than 11, it's portal hypertension, and if the SARC is less than 11, there is malignancy, TB, pancreatitis, or there is going to be a nephrotic syndrome. Management of ascites, we all know that water and salt restriction, salt to be less than 2 grams per day. And you are going to give diuretics. 2 diuretics are most commonly used: pyrrolactone, which is a potassium-sparing antibiotic, potassium-sparing diuretic, and furosemide. And you do a large volume paracentesis. What is large volume paracentesis? When you are going to remove more than 5 liters, you have to give albumin along with that. If the patient continues to have refractory ascites, you are going to consider tips over here. And any patient who is presenting with ascites for the first time in the question, always tap. That is very, very important. And always remember that SARC more than 11, immediately it would go in your mind that it's a portal hypertension. So SARC more than 11, portal hypertension. 3 causes you should remember: cirrhosis, Budd-Chiari, heart failure. SARC less than 11, non-portal. 3 causes: malignancy, pancreatitis, TB, and nephrotic syndrome. Next question is: a 30-year-old male who presents with no liver disease, tense ascites, and abdominal pain. Imaging shows the portal or the hepatic vein outflow obstruction, and the SARC is high. So SARC is high over here, that is more than 11. So what is the common cause? Here the cause will be a Budd-Chiari syndrome, because here it's written that there is no liver disease. And if you see all the other causes, that is malignancy, nephrotic, pancreatic, and tuberculous, they will all actually cause a low SARC ascites. So the answer is Budd-Chiari because it's high. Patient has hepatic venous outflow obstruction, which is a flow thrombotic state. We're going to investigate for thrombophilia, MPS, anticoagulating. We're going to do the tips. Next is viral hepatitis and autoimmune hepatitis. Again, very, very favorite for the examinations. Hepatitis B serology, you are going to actually see, you are going to have various types of viral hepatitis A, E, B, C, D. So first we'll talk about A and E 2 minutes. So A and E usually is transmitted through fecal-oral route. A usually doesn't cause very significant hepatitis. It's usually an RNA virus which is causing this infection. And hepatitis A usually spreads through fecal-oral route, usually has a self-recovery. Hepatitis E is much more common in the case of pregnant women, associated with a very, very high mortality. These are usually happen through fecal-oral route. The ones which are transmitted through vertical from mother to baby, or through sexual transmission, or through infected needles are the B, C, and D. D usually happens along with B. It never happens alone. B, we all know, is again of two types. One is an acute hepatitis, which is usually self-resolving of hepatitis B, and one is a chronic, which is very, very common, where the patients actually go into a chronic infection, the liver parenchyma is damaged, and they're going towards liver cirrhosis and they can develop a cancer. So in hepatitis B, you will always be asked regarding what are the infections which are what are the serology. So if HBsAg, that is hepatitis B surface antigen, is positive, it means that the patient is positive. If the anti-hepatitis B antibody is positive, that is anti-HBsAg is positive, it means that patient is having immunity. Immunity can be because of a past infection or most likely because of the vaccine. HBeAg, E is the envelope antigen. It determines the infectivity. IgM core, if the core antigen is positive, if it's IgM, it is acute, and if it's IgG, it is chronic. So C, that is HBcAg, if it is positive, it means that it's an acute infection, IgM, and if it's IgG, then it's a chronic hepatitis B. Whenever the patient is diagnosed, then you do the viral load, and depending upon that, you give commonly two drugs which are available. One is entecavir, one is tenofovir. Tenofovir is much more commonly used now because of much more benefits. Hepatitis C is again a commonest cause of viral hepatitis, and we all know that it is also transmitted in the same way. Again, has a very high risk for cirrhosis and carcinoma, and is curable now with directly acting antivirals. What are the directly acting antivirals which you are going to see? One is sofosbuvir, one is veltapasvir, etc. These are the directly acting antigens which are commonly given. You give them for 12 weeks or 3 months. The treatment is usually given. And after 3 months, you are going to repeat the viral load after another 3 months, that is 6 months. And if the viral load is negative, it is called as a sustained virological response. So it is that important. Third is we are going to talk about, so this is about, in short, about viral hepatitis. Very, very important, but more emphasis will be given on diagnosis, what antibodies are going to be positive and how we are going to treat it. And the next one is going to be autoimmune hepatitis. So autoimmune hepatitis, here again, the bilirubin may be increased, but the AST, ALT will also be elevated, mainly the ALT. And here, the history will be there that usually the patient is a young patient who is having other systemic symptoms in the form of arthralgia, joint pains, hair loss, etc. And when you evaluate these patients are actually going to have other symptoms in the form that they are actually going to have rashes, they are going to have hair loss, or they may have other autoimmune diseases which are going to be present. So first is you are always going to rule out viral hepatitis and hepatosimilar causes. And once that is negative, you will always think about the autoimmune hepatitis. As I said, it affects the young females associated with other autoimmune diseases. Commonly, patients present with fatigue, myalgia, arthralgia, hepatomegaly, and amenorrhea. The laboratory pattern is, again, the ALT is markedly elevated. But if you see the AMA, that is anti-mitochondrial antibody, asthma, that is anti-smooth muscle antibody, or anti-LKM1 antibody, that is liver, kidney, and antibody is present, think in the form of autoimmune hepatitis. In autoimmune hepatitis, you may be given a line that in histopathology there is interface hepatitis. So if there's an interface hepatitis, think about autoimmune hepatitis. And obviously, because it is autoimmune, you are going to treat them first with steroids, and then you are going to give other immunosuppressants chiefly. you are going to give as a therapy. So the clinical picture will be that a young female presents with very high ALT like 800, 900. Asthma is positive and IgG is positive. Always asthma, AMA or anti-alkane. Think about autoimmune hepatitis in this picture. Okay. Second is primary biliary cholangitis, which is important. So primary biliary cholangitis is usually going to be seen where there is an autoimmune destruction of the small intrahepatic bile ducts. So primary biliary cholangitis is actually going to be seen in this destruction of the small intrahepatic ducts, commonly seen in young females. And again, it's going to present with, because it's going to have more features of obstruction, because the bile ducts are going to be destroyed. Patients will present with cholestasis, itching, xanthal asthma, dry eyes, hyperpigmentation. We're going to see elevation of ALP and GGTP. And here the AMA antibody is going to be strongly positive. So middle-aged women, intrahepatic bile destruction, AMA positive itching. Think about primary biliary cirrhosis, and there is a granulomatous destruction of the bile ducts. Treatment is going to be uricodeoxycholic acid, which is commonly used. So young middle-aged female, itching, AMA positive. Think about primary biliary cirrhosis. Just 2 minutes. Regarding primary sclerosing cholangitis, it is going to be associated with inflammation and fibrosis of the large intra and extrahepatic ducts, usually seen in younger patients with ulcerative colitis. If I have a question where there's an ulcerative colitis which is going to be present, think about the primary sclerosing cholangitis. Okay, so again, they will present with itching, they will present with jaundice, cholangitis, and here the P AMCA will going to be positive. We're going to do the MRCP, and here you're going to see the dilatation, narrowing, like a bead of pearls. So a beaded appearance is going to be seen. There is actually not much treatment for primary sclerosing cholangitis, but think about young male ulcerative colitis developing jaundice. You should always think about primary sclerosing cholangitis. Hemochromatosis usually is an iron overload disorder. Suppose patients like thalassemia or other patients where the iron metabolism is going to be affected are actually going to have the hemochromatosis, and here the patients are going to present classically with bronze skin. They're going to have diabetes, they're going to have cardiomyopathy because of the deposition of the gonads. So, when hypogonadism, they will have arthropathy. How do you diagnose them? The ferritin and T-sats, that is transferrin saturations, are very, very high. It's hemochromatosis. You do a genetic testing, and the genetic testing is going to show that the transferrin saturation is more than 45%. And the treatment is going to be regular venesection, which is the treatment of choice. And the patients usually have something called as a bronze diabetes. Okay. So this is very, very important. So the next question is, a 48-year-old male, a 40-year-old woman has fatigue and itch. ALP and GGTP are raised. So when ALP and GGTP are raised, think about cholestasis. ALT is normal, so you better assume it gets ruled out. An antimicrobial antibody is positive, so always think in terms of PBC, that is primary biliary cholangitis, which is very, very important. Okay. So as I said, it is associated with other autoimmune diseases, and primary sclerosing cholangitis is associated with young males with ulcerative colitis. You treat primary biliary cirrhosis with the case of uric acid. Okay. Next, which is very, very important again from the exam point of view, is the inflammatory bowel disease. So we all know that inflammatory bowel disease are actually going to be of 2 types. One of them is going to be Crohn's, and the second one is ulcerative. There are some very simple mnemonics which you have to follow for this. So the first of them is always going to be the ulcerative colitis. Here it is going to affect the colon, and the Crohn's is going to be throughout. So how do you remember it? It's very, very simple. You should remember that Crohn's disease is from mouth to anus. So because their distance is very, very long, it's not going to be continuous. Nobody can travel such a long distance continuously. Ulcerative is only in the colon, so it's short distance, so it's a continuous disease. Okay. So Crohn's disease, usually mouth to anus. Skip lesions are there because it can't be traveled continuously. It's transmural, involves most of the layers of the gut. There is a granulomas which are going to be seen, and strictures of fistulas are going to be present, and smoking worsens this illness. Whereas ulcerative colitis involves only the colon, it's a continuous and it is only mucosal, doesn't affect all the layers. Here it's going to affect all the layers. Here the patient has bloody diarrhea. Ulcerative colitis, we previously studied, has a PSC link and it's going to be protected. So acute severe ulcerative colitis may present with severe bleeding, bloody diarrhea, pain, etc. And you have to always remember that the treatment is always going to be IV steroids. And you have to actually do the rescue by giving them cyclosporin or infliximab. And if all this fails, then you have to treat it with a case of surgery. Next is going to be, what do we say is the maintenance. So maintenance is always going to be by giving them steroids first, and then in ulcerative colitis, you're always going to treat them with aminosalicylate, that is mesalamine, which is commonly used, or mercaptopurine, and very rarely the biologics like infliximab, adalimumab, etc. are going to be used. What are the complications which we are going to see over here? One of them is toxic megacolon, which is very, very common. Secondly, you're going to see you have to do the colorectal surveillance, and you have to see for extra intestinal features. What are the extra intestinal features you will see? One is erythema nodosum. One is scleritis, which are some of the extra intestinal features which are going to be seen. Okay, so just to recapitulate, so Crohn's, mouth to anus, hip lesions, transmural granulomas, that is ulcerative colitis, only colon, and it's going to be continuous. That is going to be mucosal octave abscesses in the case of ulcerative colitis. Crohn's presents more with strictures and fistulas, whereas ulcerative colitis actually presents more with bloody diarrhea. Smoking worsens Crohn's, whereas ulcerative colitis, smoking is protective and it has a primary sclerosing cholangitis links. There's a severe ulcerative colitis, you're going to treat it with steroids and you have to give it rescue cyclosporin infliximab. Where the patient has bloody diarrhea with continuous inflammation, think about ulcerative colitis. So just to recapitulate very important points, if it's a continuous disease, ulcerative colitis. Crohn's is skip lesions. Always remember that continuous can never be C and C are not together. So continuous ulcerative, skip lesions is going to be Crohn's. Transmural, Crohn's. Granulomas, Crohn's. Perianal fistulas, Crohn's, which is very, very important. Now, how do we differentiate between IBS and IBD? You may get a question. So fecal calprotectin is very, very sensitive. It may be positive in inflammatory bowel disease, will be negative in idiopathic, or it's going to be negative in irritable bowel syndrome. Colonoscopy confirms the diagnosis. We do an MR or a CT angiography for small bowel Crohn's disease. Toxic megacolon is a very important complication where the diameter of the colon becomes more than 6 centimeters. IV steroids are the first line therapy which is commonly used. Rescue therapies with the help of infliximab or cyclosporin, and long-standing, if you actually go on treating the long-standing ulcerative colitis, can actually increase the risk of cancer, which is very, very important. So young adult has bloody diarrhea, continuous colitis, and has PSA, that is primary sclerosing cholangitis, think about ulcerative colitis. Young patient, weight loss, terminal ileum, cobblestoning, skip lesions, fistulas, or strictures, think about Crohn's disease. IBD with cholestatic liver enzymes, pruritus, always think about primary sclerosing cholangitis. Patient has severe ulcerative colitis and the colonic diameter is more than 6 centimeters. If you do an X-ray and the colonic diameter is more than 6 centimeters, toxic megacolon, urgent decompression and surgery is required. And if the raised fecal calprotectin is there, it's going to be suggestive of inflammatory bowel disease. So a 25-year-old patient is admitted with ulcerative colitis, is admitted with 9 bloody stools per day. He has fever, tachycardia, and a raised CRP. And he started on IV anti-hydrocortisone. He has not improved. And the the abdominal X-ray shows a colonic dilatation of 5.5 centimeter. The treatment here is you are going to give a rescue therapy with surgical review. Because if you actually do not treat it, it's like an early toxic megacolon. So the cyclosporin and infliximab with surgical input is going to be there. You do not give Lomotil or other anti-motility agents. because there may be a risk of worsening. Now, quickly, what is about malabsorption? In malabsorption, you are going to be chiefly asked regarding TTG, that is trans tissue glutamase or celiac disease. So we all know that celiac disease is actually quite common. Okay. So in the case of celiac diseases, what happens is that so what is in celiac disease? So celiac disease, what happens is that there is usually a problem where there is a signs hypersensitivity to gluten, and because the gluten is actually affecting the problem, it causes malabsorption. So how do these patients present? These actually patients present with the form of weight loss. They have diarrhea, they have a lot of bloating, and because the absorption is not proper, they have iron deficiency anemia, they have osteoporosis, which is much more common, and they can actually present with dermatitis herpetiformis and peripheral neuropathy. Okay. So if there is a patient who is presenting with iron deficiency anemia and bloating, so any GI symptoms of bloating, gas, diarrhea, weight loss, think about celiac disease unless until proven otherwise. How do you diagnose celiac disease? Celiac disease is diagnosed by doing a blood anti-TTG IgA. IgA it is done. Okay, so if the IgA levels are normal, the test may come positive. When the IgA levels are low, the test becomes falsely negative. So whenever you are diagnosing a TTG or a celiac disease, always you have to do a duodenal biopsy before putting the patient on a gluten-free diet. If your patient requires a gluten-free diet, you have to first do the duodenal biopsy, prove that the patient does have this thing, and it's going to show the villus atrophy and hyperplasia is going to be seen. And the treatment is only going to be lifetime gluten-free diet in most of these diseases. Celiac disease is again autoimmune. Autoimmune hepatitis, diabetes, Turner's, Downs, etc. It is going to be much more common. You have to give them gluten-free diet. And along with the gluten-free diet, you have to treat all the complications like iron, calcium. You have to treat with iron, calcium, vitamin D, folate, etc. It's very, very important. So you do a TTG, IgA, and then you do a duodenal biopsy. Now we all know that acute pancreatitis, the causes we have all remembered one mnemonic, but eye gets smashed. Eye gets smashed is idiopathic, gallstones, yeast, ethanol, trauma, steroids, mumps, scorpion, etc. So this is very, very common. So most common reasons are two. One is alcohol and one is gallstone. And here the patient is going to have a severe epigastric pain. The pain is going to be migrating to the back or radiating to the back, and the pain is very, very severe. The patient is going to be bent in the front. That is a severe kind of pain the patient is actually going to have. So for the diagnosis of acute pancreatitis, you at least need two of the three features. But the two of the three features, the patient has characteristic significant abdominal pain. Secondly, the lipase and amylase are going to be elevated more than 3 times the upper limit of normal, and the CT is going to show pancreatitis. The patient doesn't have pain, but amylase lipase is elevated and CT is showing the features, so that can be pancreatitis. Out of amylase lipase is more sensitive as compared to this thing, and you are going to do a score severity by doing called as Glasgow scores. And if the Glasgow score is more than 3, it is severe. Okay, so the Glasgow score, if it's more than 3, is for the severe. Mostly you are going to get IV fluids and early enteral hydration. If there's a necrotizing pancreatitis, you need a surgery. Chronic pancreatitis, usually there's an exocrine failure. If the patient has repeated pancreatitis, the patient can go into a chronic pancreatitis. Here, the patient has exocrine failure. So because the pancreas are affected as a whole, the patient continues to have abdominal pain, digestion issues, has diabetes. And the treatment is by giving the pancreatic enzymes, like pancreatin, etc., commonly replaced. Two things about esophagus in very short before, because we are running short of time. So two things. One is achalasia. We all know that achalasia is the dilatation of the esophagus in the upper end, and there is a muscle failure of the esophageal sphincter. And there's a dysphagia, which is characteristic, very, very classical to solids as well as liquids, but more so to the case of liquids. In that situation, it's called as achalasia. Achalasia means a parrot beak appearance is actually going to be seen. So in the case of achalasia, we all know that the patient is going to have a bird beak appearance on barium. And what are you going to do? You are going to do a pneumatic dilatation of the esophageal end. What is Barrett's esophagus? Barrett's esophagus, we all know, is nothing but the dysplasia of the lining of the esophagus. So whenever there is a repeated reflux which is going to happen, it is going to cause the dysplasia, and it is a risk factor for developing cancer. Okay. So the pearl is that if the patient presents with an iron deficiency anemia and bloating and diarrhea, always think about the celiac serology. That is very, very important. Some important pearls I'll consider here. So iron deficiency anemia, diarrhea, bloating, think about celiac disease. Anti-TTG, IgA is the treatment of choice. Do the biopsy first, real-time biopsy, and then put the treatment. Lipase is more sensitive than amylase. Do a CT within 72 hours. Antibiotics are not routinely used for pancreatitis, and you have to actually treat these patients by giving them IV fluids and early anticoagulation. Gold standard is going to be what is the esophageal manometry for achalasia cardia, and Barrett's esophagus will predispose to a carcinoma. So the next question is, a 35-year-old male has a chronic diarrhea, has bloating and iron deficiency anemia. And here they're directly given that the tissue transglutaminase IgA is strongly positive. So here the treatment is going to be whether you will directly start gluten-free diet or you will do a biopsy. So always remember that biopsy is number one, and then you have to do a gluten-free diet, because if you actually put them on a gluten-free diet, you may miss the diagnosis of these patients. So just a recap of what we have studied. So liver function test, see what is predominant, whether it's a cholestatic or a hepatocellular jaundice. Think about bleeding in the form of upper GI and lower GI bleeding. And if it's a varicose bleed in cirrhosis, always think about getting terlipressin. Ascites, portal hypertension, cirrhosis, always see the WBC count. If the patient has a palpable gallbladder with painless jaundice, think about pancreatic cancer, that is called a Schulweiser sign. An acute severe feeling ulcerative colitis, think about rescue therapy like infliximab or cyclosporin and surgery. Next, just very, very important, which you will always have to remember for your exams, because these are commonly asked in MRCP exams, are the various inherited and metabolic diseases. So hemochromatosis we have already discussed, where increased ferritin and transferrin and Crohn's diabetes is present. The treatment is venous section. Wilson's is actually an abnormal deposition of copper in the liver, and here it's commonly seen in young patients who have copper metabolism defects, and they are having multiple neuropsychiatric issues. And in the cornea, you're going to see Kayser-Fleischer rings. Okay, so if you see Kayser-Fleischer rings in the cornea, think about Wilson's. Treatment is penicillamine and zinc. In alpha-1 antitrypsin deficiency is responsible for two diseases. One is a COPD and one is a liver disease or cirrhosis. And the treatment is avoiding of smoking, which is very, very important. But before we wind up gastro, just lastly, I'll tell you that a 50-year-old man has lethargy, joint pains, bronze skin, and impaired glucose tolerance. Ferritin is markedly raised and transferrin saturation is also markedly raised. This is suggestive of what we call as a hemochromatosis. So it's hereditary hemochromatosis. So raised ferritin, raised transferrin saturation, bronze skin, arthropathy, and diabetes. To confirm the genotype, treat with venesection, and they have high risk for HCC. Next is a 55-year-old male presents with gallstones, develops severe epigastric pain, which is radiating to the back, has vomiting, and lipase is 5 times the upper limit. Glasgow score is 4 with a raised CRP. What will you do over here? Here you are going to see aggressive iris fluids, analgesia, and HDO monitoring. So this is a classical case of acute pancreatitis because lipase is elevated more than 5 times. So NG liver enzymes elevated more than 3 times. And Glasgow score, which is more than 3, it indicates it's a severe pancreatitis. The answer here is B. You are going to do aggressive fluid resuscitation. You're going to give analgesia and ICU HDO monitoring. MRCP is going to be done if there is a gallstone or there is an obstruction of cholangitis, which is going to be associated with the pancreatitis. Okay. So thank you for your kind attention. We have finished the first part of today's lecture, which is about gastroenterology. Obviously, in the last 5 minutes, we can again recapitulate whatever we have studied because it's a marathon series. We try and give you all the important pearls so that you are able to grasp and make the maximum benefit of this. In a minute's time, we'll go to the next topic of infectious diseases. So before that, just a small announcement that Study Medic is now conducting MRCP cases where there is a 2-day live on-site course also available, as well as there is a 1-to-1 mentorship program, which is also the Study Medic is offering. So we'll just take a minute's break, and in a minute we'll start with the infectious diseases. In the meanwhile, if you have any doubts, if there are any questions, anything which has gone really fast and you have not been able to grasp it, you can please message our team. They'll get in touch with us and we'll try to solve all your queries which you have. Okay? So without wasting much time, I'll go to the next topic of infectious diseases. So that infectious diseases we are also going to have. So in infectious diseases, again, just as GI, infectious diseases is going to cover around 19 plus 19 questions, around 9.5%. So approximately 19% of your exam is going to be covered by these two topics. In infectious diseases, you are actually going to have a lot of important things. First one is I'm going to read about is sepsis. So we all know that sepsis is very, very commonly asked in the examinations. And we all know that sepsis is actually going to have what is called as, before we go further in sepsis. So what is sepsis? Sepsis is actually a life-threatening organ dysfunction, which is caused by the dysregulated host response to infection. So any life-threatening organ dysfunction which is happening because of a dysregulated host response to infection is called as sepsis. And in the case of sepsis, we have to recognize sepsis early and treat the sepsis within the first hour after recognizing the sepsis. Okay, so you have a SOFA score which is going to regulate, and if it's more than 2, it indicates that the patient has severe sepsis. And in the Q SOFA, which is a very small SOFA, you have 3 things. One is a BP, it's less than 100, a respiratory rate which is more than 22, and altered psychiatric status when the GCS is less than 15. It indicates what is called as a Q SOFA. So Q SOFA is only a screening test which we are going to diagnose. So if there is a dysregulated immune response of the host and there is a persistent hypotension, which is even after adequate fluid resuscitation, and it requires vasopressors to maintain MAP of more than 65, the high lactate, it is called as a septic shock. So septic shock, so low BP, fluid resuscitation given, vasopressors being given, and raised lactate, then it is considered to be a septic shock. So in the case of septic shock, you have to actually diagnose early and you have to deliver early. And we have something called as give free and take free in sepsis. There are 3 things you are going to give. One is oxygen, so maintain the oxygen saturation. Second is maintain the IV fluids. You are going to give the IV crystalloids, which are very, very important. And third is you are going to give the IV antibiotics, so broad spectrum antibiotics. So any patient is coming to you with sepsis, give them oxygen, give them crystalloids to fluid resuscitate them, usually 30 ml per kg, and broad spectrum antibiotics. Take 3 of them. What I want to take, I'm going to take blood cultures to see what is the organism which is causing the sepsis. Lactate, if it's more than 2, you're going to be associated with hypoperfusion. And you're going to take the urine output. So you're going to put a catheter and monitor it. Do not wait for cultures. If the patient comes with sepsis, give the antibiotic. Cultures can be taken later. Antibiotics within 1 hour or the golden period is very, very important if the patient is actually having. Now, so first you actually have to find and control the source, but you have to not delay the antibiotics. Give the antibiotics and then you control the source. You choose the antibiotics depending upon where the organism is. If there is a pyelonephritis, you treat mainly with gram-negative. If there is an infective endocarditis, you give more of gram-positive cover. If there is a local resistance, renal function, you have to monitor everything. You have to see their travel and exposure history, whether they have been having recent travel and if they are having any history of malaria, dengue, viral fever, etc. and immunocompromisation, which may also be affected, and in the patients may actually have opportunistic infection, where I'll be talking about HIV, etc., which is very, very important. Okay. So in undifferentiated sepsis, always take blood cultures and give antibiotics, but you never ever wait for this thing. As I said, that sepsis is a dysregulated organ dysfunction with a dysregulated response to the infection. Always give oxygen, fluid, antibiotics, and you take cultures, lactates, urine output. Fluid resuscitation with crystalloids, preferably normal saline, admin solution, or reverse lactate or plasma-like. To reassess, you give them vasopressors. Vasopressors of choice is not generally a fluid refractory. Lactate reflects hypoperfusion and drives resuscitation. And escalate to critical care for refractory shock, which is very, very important. The aim is to maintain a blood pressure of more than 65. Dopamine is not routinely recommended because of additives. Noradrenaline, second is vasopressin, which is very, very important, which is extremely important and essential. So SOFA score will tell you about organ dysfunction. Q SOFA will tell you about the poor outcome. Antibiotics to be given within 1 hour. Do not delay treatment. Fluid resuscitation is 30 ml per kg. MAP, you have to maintain of more than 65. So what is MAP? Systolic minus diastolic. Systolic plus diastolic upon systolic blood pressure. So 2 systolic plus diastolic upon systolic, and whatever MAP you are going to get, that you have to, systolic. So the MAP should be more than 65. Lactate is diagnostic and prognostic, and you have to give the early treatment. So 70-year-old man with a urine source of infection is hypotensive. BP is very, very low, 86/46, and is confused. The lactate is high. After 30 ml per kg of crystalloids, continues to have low BP. Cultures and antibiotics have been given. What is the further treatment? So here the treatment will be to give noradrenaline, and you have to escalate to the critical care. Okay, so as I said, that you first resuscitate with fluid, still it is less, it has a high lactate, you have to give the antibiotics. Secondly, this is in short about sepsis. Second topic that I will be covering is meningitis, and we all know that meningitis is an inflammation of the meninges, which is commonly happening. And meningitis patients actually present with high-grade fever or fevers. They have a severe headache, and characteristic, they also present with neck stiffness, photophobia, and sometimes if there's a meningococcal disease, they may have a non-blanching rash. So always remember, young patients, fever, severe headache, always meningitis and encephalitis should come to our brain. If they are having photophobia, neck stiffness with plus minus rash, think about the case of bacterial meningitis, which is very, very important. So after the bacterial meningitis, we always know that. So meningitis, again, it is of various types. One is bacterial meningitis, one is viral meningitis, one is tubercular meningitis, one is fungal meningitis, which is more common in case of older individuals. So in neonates, the group B streptococcus or E. coli are more common. In 18 to 50 years of age, which are not immunocompromised, Neisseria meningitidis or strep pneumonia are the most common causes. If more than 50 are immunocompromised, think about strep pneumonia or listeria. So listeria in immunocompromised is very, very important. And we have already discussed the features which are commonly going to be present. You have to actually do lumbar puncture unless you have the signs of raised ICP, focal signs of decrease, IGCS. So if you have raised ICP signs, like you're going to have papillary edema, GCS is going to be reduced, or the patient has focal signs, then you are going to treat them with the case of antibiotics, and then you are going to do the LP later. Okay, that is very, very important. But otherwise, you have to do the lumbar puncture. So in lumbar puncture, you are going to see the pattern, which is going to be very, very common. So the patient actually presents with high neutrophils and low glucose. Think about bacterial meningitis. It has lymphocytic predominance and 10 to 100 cells with normal glucose. Think about viral meningitis. What is the empirical treatment you're always going to give to these patients? The first empirical treatment is IV ceftriaxone because it usually works well against both Neisseria and strep pneumonia. which is actually going to be much more useful. So you are going to give that antibiotic, and if it's more than 50 or immunosuppressed, you are always in your listeria and give amoxicillin. And you will give dexamethasone to prevent what is called as the exudates in the meninges. So you will give a single shot of dexamethasone. Now, if the patient actually presents with what is called as a rash, if the patient has a purpuric rash, he has DIC, meningococcemia, you have to always suspect. So DIC, shock, purpuric rash, which is called as Waterhouse-Friderichsen syndrome, which is very, very common in the case of Neisseria meningitis, and it can actually occur in the community. You have to give benzyl penicillin and transfer immediately, and you can give chemoprophylaxis by either giving rifampicin or ciprofloxacin. Okay, so never delay treatment for meningitis. If the patient if you are thinking of meningitis and if the patient is critical and you can't do the LP because of raised ICP, you are going to directly give antibiotics and dexamethasone, and then you are going to do the CT and LP. If the patient has no signs of focal deficit or ICP, you directly do the LP first and then the antibiotics. Empirical antibiotic is ceftriaxone, and if above 50, you are going to give Neisseria meningitis. And if also dexamethasone, and if the patient presents with rash, fever, and non-blanching purpuric rash, you are going to give benzyl penicillin, and you are going to transfer the patient to the ICU. Okay. The next question is that a 25-year-old has fever, neck stiffness, severe headache, and phobophobia. He is alert and no focal deficit of papilledema and no rash. What is the treatment you are going to offer? Whether you are going to do CT first, second is you are going to do LP first and then IV antibiotics plus dexamethasone. Third is you are going to give IV acyclovir. Fourth is oral antibiotics. And fifth is reassure and you are going to discharge. So here is going to be option B, because here there are no contraindications to LP. So first you'll do the LP, diagnose the type of this thing. And if no, give antibiotics and CT first. Second is, this is about meningitis in short. The next thing that we are going to study is about HIV. Okay, so HIV we all know is a very, very common infection, and HIV is actually called as a retroviral infection, which is caused by what is called as the retrovirus. So it's an RNA type of virus, and it can actually happen most commonly because of sexual contact, vertical transmission, and it affects can happen through needle stick, breastfeeding, sexual contact, and needle stick injury. These are the common modes through which HIV happens. HIV is going to target three enzymes. One is the reverse transcriptase, one is integrase, and one is protease. And the HIV infection chiefly targets what is called as a CD4 plus T lymphocytes. And that is why the patients present with a very, very weak immunity, most of these patients. Now as we all know that it is transmitted this thing. So normally the natural history is that the patient gets the acute infection within 2 to 6 weeks, and they actually have a clinical latency for a long time. And then the CD4 starts declining, and then the patient goes through AIDS, which is illness defining criteria, where the CD4 is less than 200. The clinical stages are very, very simple. It has 4 stages. In stage 1, it is asymptomatic or only persistent generalized lymphadenopathy state. Stage 2, the patient may have herpes zoster, recurrent infection, oral ulcers, etc. Stage 3, the patient may have tuberculosis, candidiasis, or significant weight loss. And stage 4 is AIDS, where they may have Kaposi sarcoma, pneumonitis, toxoplasma, local meningitis, cerebral lymphoma, etc., which is going to be present. You diagnose them by doing what is called as a 4th generation HIV antigen antibody assay, which is very, very important. You do a CD4 count, you do a viral load, and you do all the other screenings like hepatitis B, C, syphilis, etc. should be done. Now, in HIV, you will always be asked regarding what are the opportunistic infections which will happen in these patients. So what are the opportunistic infections? Is the CD4 counts are less than 200, you should always, normally if it's 200, you always have to think about PCP, which is or esophageal candidiasis, is very, very common. Less than 200, think about PCP, that is pneumocystis jirovecine pneumonia. Less than 100, think about toxoplasmosis, that is ring enhancing lesions and cryptococcus meningitis. And less than 15, two. One is CMV retinitis and MAC, that is Mycobacterium avium intracellular complex. So please mark this up. And based upon the CD4 counts, you'll be asked in your exams what are the question which is there. Okay. Antiretroviral therapy, we all know that a lot of drugs are now available, and we all know that multiple drugs are available. One of them is the integrase inhibitors, dolutegravir, protease inhibitors, you're going to have NRTIs, NNRTIs, etc. So they will be asked to your exam. So preferred, we are giving TLD, that is tenofovir, lamivudine, dolutegravir, NRTIs and NNRTIs, integrase inhibitors and protease inhibitors. So any patient of HIV, irrespective of the CD4 count, you have to treat them with the antiretroviral therapy. And when you start antiretroviral therapy and the CD4 count is very, very low, always think about ILS, that is immune reconstitution inflammatory syndrome. So when you give the antibiotic, when you give the ART, suddenly if they have a tuberculosis or something inside, it can actually flare up after giving them. So that is very, very important, which is extremely important. So you will have to mug up these things. So it's less than 200 PCP, treatment is by cotrimoxazole and prophylaxis. Less than 100 toxoplasma and cryptococcal meningitis, and less than 50 CMV and MAC. And if the person has a CD4 of less than 200, always start with cotrimoxazole whenever it is stuck. So here a patient presents, 34-year-old male who is recently diagnosed HIV. CD4 is 90, has 3 weeks of dry cough, exertional dyspnea and hypoxia. Chest X-ray shows bilateral perihilar interstitial shadowing. The treatment is going to be cotrimoxazole with steroids for hypoxia. Okay, because it's the PCP pneumonia. So next we are going to read in quickly regarding what is fever in a returning traveler. Okay. So we all know that you will always be given some questions where some male has traveled to Far East, has traveled to Africa, and now has come with fever. So you will actually have to choose this. So before I proceed to a fever in returning traveler, there are some tips you should always remember. So any fever in a traveling person, always keep malaria very high on the list. And even if one peripheral smear is negative for malaria, it does not exclude it, which is very, very important. You have to do at least 3 tests for malaria, 12 hours apart, along with an antigen test. And if everything is negative, then we think about, then we exclude the malaria. So 3 thick and thin films with antigen tests, you have to do it in the case of malaria. So normally, malaria is one of the most common fever in returning traveler. Patients present with fever, severe malaise, body pains, splenomegaly, thrombocytopenia, anemia, jaundice. We are going to exclude it by doing thick and thin films that 3 in number. A malaria rapid antigen test, you do a CBC to see the thrombocytopenia and anemia. You do LFT to see for jaundice because of hemolysis, and you do a urine examination to see it is being detected. Posting the falciparum malaria, which causes a severe disease, and it causes a severe malaria. Here the patient presents with cerebral malaria. The patient becomes drowsy, patient becomes altered. We have a white bleed when anesthesia. It can cause renal failure and hemolysis. And the treatment is you are going to give IV artesunate in these patients, which is very, very important. Okay. Typhoid. Typhoid is caused by Salmonella typhi, which is a bacterial infection. Usually you will get a case where a young man has traveled to Thailand or India, etc. and has had a lot of outside food and now is having fever after 1 week, and the patient on examination has relative bradycardia, and he is traveling to the South Asia, and the fever is going to be a step ladder kind of fever. So gradually it is going to go on increasing. Patient has relative bradycardia. So the pulse is not going to be that high as compared to a fever. Patient has rose spots which are going to be seen at hepatosplenomegaly. Think about typhoid. We're going to do it in the form of PASU, that is the non-inclusive member, blood cultures in the first week, antibody Vidal in the second week, stool culture in the third week, and urine culture in the fourth week. And treatment of choice is always going to be ceftriaxone and azithromycin. Next is dengue. We all know that dengue is caused by a virus which is called as a flavivirus. And it has 4 serotypes. Again, very, very common after travel to Southeast Asia or other places of low-income countries. A lot of mosquitoes are present. Presence with high-grade fever, a bone break type of fever, severe myalgia, retroorbital pain, leukopenia, thrombocytopenia, etc. Diagnosis is by NS1 antigen present in the first 2 or 3 days, and IgM up to 7 days can be positive. Causes a lot of this thing. Treatment is usually supported and you watch for bleeding, etc. Okay. You should always remember about chikungunya, which is again caused by the mosquitoes, which is causing the chikungunya, and leptospirosis when they travel in the mud and the flooded rainwaters, and when they're traveling and the mice urine, which is causing this leptospira, which is a type of spirochetes, it is actually going in the water, and that spirochetes is responsible for causing the leptospirosis. We are going to have other infections like schistosomiasis, which is called as Katayama fever, and where the scenario will be of freshwater swimming in Africa, and patients will have fever, eosinophilia. Rickettsial diseases when the person travels to the mountain and has a tick bite or has a eschar, and the treatment is going to be doxycycline. Here we have not enlisted all, but all these, that is schistosomiasis, that is Katayama's fever, rickettsial diseases or scrub typhus, leptospirosis, chikungunya, they have all the various types of fever in a returning traveler. Okay, which you have to remember. So as I said, that malaria will have thrombocytopenia, cerebral malaria, and ACTA will be falciparum malaria. Dengue is myalgias and thrombocytopenias. Typhoid is relative bradycardia and rose spots. Chikungunya with a lot of joint pain or severe arthritis. Schistosomiasis or Takayamas, freshwater swimming, Africa, and eosinophilia. Leptospirosis, conjunctival suffusion, and Gill's disease, that is hepatorenal syndrome will be there. Rickettsial fever, you will always get a clue regarding the eschar. Okay. So unless until proven otherwise, first is malaria, falciparum treated in ICU with IV artesunate, typhoid treated with ceftriaxone plus azithromycin, dengue only supportive care, which is very, very important. So a traveler returns from West Africa with fever, rigors, and headache. Blood shows ring forms with 6%, is jaundiced, drowsy, and has a high lactate. So these drowsy is cerebral malaria. High lactate means he is in shock. Treatment is going to be IV artesunate. This is the severe malaria which is going to be present. Chloroquine is a drug of choice, but there is a widespread resistance. So IV artesunate is a treatment of choice, which is extremely important and essential. Now moving further, we are going to read about what is antibiotic resistance and what are the empirical antibiotics which we have to actually study. This thing. So normally, if you actually have an infection and when you get a case, you actually have to first try and give an empirical antibiotic depending upon what it is. You start empirical antibiotics, you obtain the culture, and then you de-escalate based upon the gram staining and culture guides. That is very, very important. So never continue broad spectrum antibiotics once we have got the treatment. For example, there's a patient who was treated with septic shock on President-Bazolactam plus vancomycin, and now the blood is showing MSSA, that is methicillin sensitive Staphylococcus aureus. You immediately de-escalate to flucloxacillin, which is very, very important. No need to cover the vancomycin. If the patient has UTI or cystitis and it is having nitrofurantoin sensitivity and patient is on levofloxacin, stop the levofloxacin and shift to nitrofurantoin. So that is about antibiotic de-escalation, which is very, very important. So first you always give an empirical therapy and then you actually switch them to the definitive therapy, which is extremely important. We all know that because of rampant use of antibiotics, lot of resistance is actually now happened. One of the key resistance is MRSA, that is methicillin-resistant Staphylococcus aureus. And here the mechanism is going to be through the MEK8 gene. It affects the penicillin binding protein 2A, and this makes the beta-lactams ineffective. The treatment of MRSA is going to be linezolid, clindamycin, and doxycycline. Severe infection, you can give daptomycin, teicoplanin, and you can get vancomycin also. So daptomycin or vancomycin only in severe cases. ESBL is extended spectrum beta-lactamase resistance, where they're resistant to the case of meropenem, and this is commonly seen because of seen in E. coli and Klebsiella. Here you actually have to treat them with carbapenems, and when you use these antibiotics for a long time, then you can actually develop CRE, that is carbapenem resistant enterococcus, carbapenem resistant bugs. Here you will not be very much asked in your MRCP examinations. This is more for other things. For the treatment of choice, here will be ceftazidime, avibactam, etc. Next is when you give these patients long-term antibiotics, it can actually affect the gut bacteria. And when you are giving clindamycin, piperacillin, tazobactam, fluoroquinolones, etc., then all this will actually cause what is called as the Clostridium difficile infections, which are very, very common. So Clostridium difficile infections are happen if the patient has an extended stay in the hospital, is given long-term antibiotics, is given a lot of PPIs, etc. And patients start developing fever, high counts, watery diarrhea, and raised creatinine in a lot of patients. Here you are going to do the toxin A and B of the Clostridium difficile and the GDH, which will confirm the test. You stop the offending agent and you put the patient on metronidazole and oral vancomycin. Please always remember that C. diff. Always treat them with this thing, which is very, very important, with this thing, which is very, very important. Next is that you have to do penicillin allergy. So a lot of times we'll get a patient with penicillin allergy, but it is not always truly allergic to penicillin. The features actually have an IgE allergy. The IgE levels may be raised, and the patients are present with classical anaphylaxis in the form of urticaria, rash, angioedema, anaphylaxis, etc. If the patient has penicillin allergy, try and avoid cephalosporins because it can cause this problem, which is very, very important. Next is, so here if the patient comes to you only with diarrhea, then it's not an allergy. But if he gets urticaria, angioedema, rash, etc., then it's an infection. Okay. Next is therapeutic drug monitoring. So this is normally done for disease drugs which have a very narrow index, like vancomycin, gentamicin, etc. And antibiotic stewardship is nothing but de-escalating antibiotics quickly and reviewing them at 48 hours. Okay. So this is a question which is very, very important. That a patient with an amoxiclav develops profuse watery diarrhea with fever and abdominal pain, and stool is positive for C. diff toxin. What is the treatment of choice? So oral vancomycin and metronidazole are the treatment of choice. So oral vancomycin is a treatment of choice. If the patient develops toxic prolonged and is not responding, the fecal transplant is the treatment of choice. Next is infective endocarditis. So you will be also one of the very, very favorite questions in our exams are infective endocarditis. And in infective endocarditis, we all know that there is infectious, affection of the endocardium of the heart. That is nothing else but a infective endocarditis. Most commonly, we all know that it is the surface of the heart valves which are commonly involved. If a patient presents with fever and murmur, it is infective endocarditis unless proven otherwise. We always have some risk factors like diabetic, elderly, poor dental hygiene, prosthetic heart valve, rheumatic heart disease, congenital heart disease, IV drug abuse, etc. These are the patients who will actually come with the infective endocarditis. What are the commonest organisms for acute infective endocarditis? So most common is Staph aureus, which is most commonly seen in intravenous drug users. So if the patient you have any history of IV drug abuse, Staph aureus is the most common. It presents very, very rapidly. Toxic patient, bile destruction, and can cause septic and coli, and the patient can actually die. Okay. Subacute, usually it is over few weeks. That is most commonly by streptococcal viridans or enterococcus. Usually can be seen in patients who have a prosthetic heart wall or who are actually having poor rental hygiene, etc., which is very, very common. In prosthetic heart wall, if it is less than 1 year, then it is most because of staph epidermidis, aureus, etc. And if it's more than 1 year, then it's similar to the native this thing, which is very, very common. Okay. Now, in right-sided endocarditis, you are going to have mainly IV drug abusers, so you will be given a history. So, usually the tricuspid valve is most commonly affected, and patients can present with cavitary lung lesions or cavitary lung abscesses or pulmonary emboli. In left-sided lesions, you are actually going to have mitral, or you're going to have aortic valves, which are actually going to be affected. So, in mitral or aortic valves, you are going to be affected in the left-sided lesions. Here, you will have systemic features, like you can have a stroke, infarct, ischemic infarct, lung ischemia, renal infarct, etc., which is going to be commonly seen. Obviously, in infective endocarditis, you will be seeing a new murmur or a changing murmur. You will see a heart failure. You will see peripheral spines like sphincter hemorrhages. You will see Janeway nodes and osseous nodules, etc., or broad spots in the retina, which are going to be commonly seen in the retinal hemorrhage, which is extremely important. And you treat it accordingly. So, as I said, that infective endocarditis, any person with fever and a changing heart murmur is infective endocarditis unless proved otherwise. You have to take 3 sets of blood culture and you do echocardiography, that is on the acute criteria. Transesophageal echocardiography is much more better than transthoracic echocardiography. And as I said, that for drug abusers, right-sided staph is the most common. Staphylococcus aureus causes acute, and viridans will cause subacute. And that is the most important, which is going to be seen. Now, the next one is tuberculosis. And in infective endocarditis, the treatment is usually for 6 to 8 weeks. So, it requires a long-term treatment in most of these patients. Tuberculosis, we all know that patients have been going to endemic countries and they are actually being exposed to a lot of organisms, which is extremely essential. So, if they are having an exposure, or they are having HIV, or they are living in poor socioeconomic countries like India or other places, then the risk of tuberculosis is very, very high. Tuberculosis is caused by an organism or a bacteria which is called as Mycobacterium tuberculosis complex. And Mycobacterium tuberculosis causes TB, and you all know that you studied in medicine, there's a Crohn's complex which is actually going to happen in most of these patients. These patients actually present with fever, night sweats, and weight loss. And they are the pulmonary tuberculosis, which is going to be the most common. Along with that, we also know that they may actually have extrapulmonary tuberculosis, which is also very, very common in these patients. And the classical features of pulmonary tuberculosis will be fever, weight loss, night sweats, more persistent chest pain. But extrapulmonary can involve pleura, can involve TB, genitourinary TB, can involve the urine, can involve bones, have a spot spine, TB, meningitis, adrenal glands, etc. can actually be involved. The sputum, you actually have to do the sputum test, and you have to do 3 sputum samples to confirm if there is AFP and TB culture on hand. You have to do it. And you are going to do the right therapy, that is just in the body, that is rifampicin, isoniazid, pyrazinamide, and ethambutol is a treatment of choice. Okay, now in MRCP, you are always asked a lot about what is called as latent TB. So latent TB means a patient may not have positive signs or symptoms of tuberculosis, but the IGRA or the tuberculin test may actually be positive. Normally, these patients are having a normal X-ray. They may have no symptoms and they're not infectious. But treatment may actually reduce the incidence of reoccurrence, especially if they are immunosuppressed. So if they're immunosuppressed and you're going to give them some biologics or steroids, etc., then it is usually you have to treat it to prevent reactivation of this tuberculosis. Now, tuberculosis and a lot of other diseases like infective endocarditis can actually caused by certain public health organizations, they should be notified. Okay, so these are the illnesses which are actually going to be notifiable to the public health. Okay, you have to notify these diseases. Okay, the next question is: an intravenous drug abuser has a fever and a new tricuspid murmur with multiple cavitating lung lesions. The blood cultures show staph aureus. So always think about option A, right-sided infective endocarditis. Here the lesions will only go into the lungs. Okay, so they will have lung lesions, drug abuse, new tricuspid murmur, and staph aureus, right-sided. You have to take 3 sets of blood cultures, echocardiography, prolonged IV antibiotics, preferably 6 weeks, and surgery. Okay, now just to recapitulate, the last part of this topic is about gastroenteritis and the sexually transmitted infections and what is called as the public health, which is very, very important. So gastroenteritis, we all know that if you are passing a lot of stools, which is going to be more than 3 new stools per day, which is lasting for less than 14 days, associated fever, abdominal pain, vomiting, panting, etc. is called as gastroenteritis. So more than 3 stools, less than 14 days, it is gastroenteritis. And most commonly, it is caused by viruses, that is norovirus, rotavirus, adenovirus, subparvovirus, astrovirus, etc. Some bacteria like Campylobacter jejuni, Salmonella, Shigella, E. coli, or protozoa like Giardia, Entamoeba, Cryptosporidium, mostly immunocompromised individual. So if the patient has bloody diarrhea after poultry, think about Campylobacter jejuni. If the patient has Salmonella, it will be eggs, okay, which will be much more common. Shigella will be bloody diarrhea in children and seizures in the case of children. EHEC, that is enterohemorrhagic E. coli, you will have bloody diarrhea without fever and HUS will be present. Vibrio cholerae, rice water stools will be present in Vibrio cholerae. Giardia, feces stools, foul smelling after travel. And C. diff will happen after antibiotics. Okay. So if the patient has enterohemorrhagic E. coli, you are only going to avoid antibiotics and you are only going to treat it as a hemolytic uremic syndrome listing. And if the patient has bloody diarrhea, again, only supported, and think about Shigella after eggs, Campylobacter after poultry, and EHEC after listing. Okay, which is really important. So sexually transmitted diseases, you always should remember that you have to diagnose them by doing the appropriate testing, preferably the nucleic antigen amplification test, that is that. You do the partner notification by doing contact tracing, and you also have to screen them for HIV and syphilis. So most common is chlamydia and gonorrhea. Most common STI is chlamydia, causes urethritis, cervicitis, PID, epididymitis. Diagnosis is by doing the NAT. We treat them by doing the doxycycline, which is for more than 7 days, which is extremely important. Or this thing, gonorrhea is also very, very common, and it is again going to be present with uterine urethral discharge, and you treat them with ceftriaxone as per the local persistence. Syphilis is usually a painful chancre, which is the primary ulcer in primary syphilis. Secondary syphilis is the secondary soles or secondary rash on the palms and soles, and condyloma lata is actually going to be seen, and tertiary you are going to see gummas or aortoarthritis and neurosyphilis. Treatment is with IV benzyl penicillin or penicillin G. Benzathine penicillin G is most common. So in this, you always have to diagnose this thing, and you always have to treat them. Now, lastly, I will also talk to you a little bit about the needle stick injury, which you will always be asked questions on needle stick injuries. So in needle stick injuries, whenever the patient comes to you with needle stick injury, always wash the needle stick with soap and water. Do not squeeze the wound. Just wash it with soap and water. Do not squeeze. You report the needle stick injury immediately. You assess the source of the infection. You check the vaccination status. If it may be a person who is infected recently, whether it's a healthcare professional or a nurse, etc. You do baseline tests for HIV, HBs, HCV, and you risk assess. So if the patient has a contact with HIV and if there is a high-risk patient or the patient is already proven, you start immediately the HIV prophylaxis within 1 hour and no later than 72 hours, and you have to give it for 28 days. Hepatitis B will depend upon the vaccination status and the anti-HBs titers, which is very, very important. Okay, if there are a lot of adults who are coming with immunosuppression, then you have to immunize them with various vaccines, which is very, very important. And you should notify them. So this is a child who is developing bloody diarrhea with oliguria, ACAD, anemia, thrombocytopenia after eating undercooked beef. Blood then shows fragmented red blood cells. The diagnosis here is HUS, that is hemolytic uremic syndrome. Treatment is usually supportive and avoid antibiotics. Most gastroenteritis require only fluids. If there is a bloody diarrhea, no fever, think of EHEC, that is enterohemorrhagic E. coli, HUS. Never give antibiotics or loperamide. Campylobacter is the most common cause of gastroenteritis in the UK. If the patient has STIs, always think about the chlamydia, which is the most common cause, which is extremely important. And post needle stick injury, you will always treat them for HIV and hepatitis B based upon the titer. So just a quick recap: with sepsis, you have to treat it within 1 hour. Fluid resuscitation and vasopressors before fluid refractory shock. Meningitis, always give antibiotics before CT if the ICP is raised. HIV, presents with hypoxia and dry cough, think about PCP, treated with cotrimoxazole. If patient is allergic to sulfur, you treat it with pentamidine. Fever with travel, malaria unless until proven. Post-antibiotic diarrhea, C. diff, treated with oral vancomycin. Next question is: a 38-year-old man presents with a high prevalence country, has chronic cough, weight loss, night sweat and hemoptysis, and chest X-ray shows an upper globe cavity lesion. Very, very simple, and it has acid-fast bacilli. It's a tuberculosis. You treat it with the right therapy, you notify, and you stain with contacts. A 30-year-old male presents with confusion, fever, and seizures over 48 hours. CSF shows lymphocytes with a high red cell count. So CSF is showing lymphocytes. MRI shows temporal lobe changes. So here the diagnosis is going to be herpes simplex. Because subacute fever is over 48 hours. Confusion, seizure, patient is having temporal lobe involvement with a lot of lymphocytes. So think about viral. So HSV and T encephalitis. Immediately start the acyclovir even before the confirmation. Okay. Next is a diabetic develops rapidly spreading extensive painful erythema on the leg with skin discoloration, crepitus, and systemic toxicity out of proportion to skin findings. The treatment here will be necrotizing fasciitis, and immediate surgical decompression should be done. We do not wait for the immediate. Next question is: a 28-year-old man presents with a painless genital ulcer with a clean base, painless inguinal lymphadenopathy, and dark-gram microscopy shows what is called as spiral cheeks. So this is clear-cut case of a primary chancre or primary syphilis. The treatment is going to be benzathine penicillin. We have to trace for other STIs like HIV or other things, and you have to notify the partner and do contact tracing. Okay. Now, this is all about the infectious diseases, and we are left with another 9 minutes to go. So this is, I would request you to take screenshots of these images because they are quite useful, like what you should never do and what you should always do. So first, never delay antibiotics for cultures in critical sepsis. Never 2 LP before CT if there are signs of raised ICP of open signs. Never do endoscopy in a variceal bleeding before drugs. Never treat an EHEC E. coli diarrhea with antibiotics. Never start a gluten-free diet in celiac disease before celiac biopsy. And never forget listeria in elderly immunocompromised meningitis and you treat it with amoxicillin. So these are all the nevers you should have. Next is always. You always give antibiotics within 1 hour of recognizing sepsis. That is the golden hour. In any meningitis, we treat them with antibiotics and CT and then LP. For variceal bleeding, give terlipressin and antibiotic and then you put a scope. For EHEC E. coli, you always treat it supportively. For celiac disease, you confirm PTAG and you do a dural biopsy and confirm the diagnosis. And if it's an elderly patient, you treat it with amoxicillin if there is a suspected meningitis because of listeria. Again, the next pearls are in gastroenterology and hepatology. If ALT is dominant, it's hepatocellular. If ALT is dominant, it's cholestatic. Variceal bleed, always give it terlipressin antibiotics. Ascitic fluid neutrophils more than 250, SBP treated with cefotaxime plus albumin. Painless jaundice with palpable gallbladder. For voice or sign, pancreatic cancer unless proven otherwise. High SAR, total hypertension. If acute severe ulcerative colitis with healing steroid, do rescue therapy with cyclosporin or infliximab plus surgery. Iron deficiency anemia with diarrhea or bloating, think about celiac serology. Sepsis, 6 hours within 1 hour. Vasopressors if fluid fail. Meningitis, we all know that antibiotics should be given with Dexa. Add amoxicillin if listeria. HIV, hypoxia, dry cough, PCP. Fever after travel, malaria, you have to do at least 3 films. Severe falciparum malaria, treated with IV artesunate. Post-antibiotic diarrhea, you treated with C. difficile or oral vancomycin. Lastly, if there's a Charcot trial, then there is a pain, fever, and raised bilirubin. It's cholangitis, and you treat it with antibiotic and biliary drainage. If there is confusion and hypotension, it's the Reynolds Fed-Card. AMA positive and cholestatic plus each primary biliary cirrhosis treated with uric deoxycholic acid. HBsAg antigen plus IgM4 acute hepatitis B. IgG4 chronic hepatitis. Young male with hepatic vein obstruction, think about Budd-Chiari syndrome. High ferritin with transferrin saturation, think about hemochromatosis, do venesection. Encephalopathy, think about lactulose rifampicin and find the trigger. AST more than ALT, think about alcoholic hepatitis. Intravenous drug abuse with right-sided murmur with septic emboli, right-sided infective endocarditis. Fever plus pneumorban cultures. Typhoid, relative bradycardia, crow's spots. Toxoplasma, ring-enhancing lesions less than 100. CMV retinitis marked by the CD4 is less than 50. And any needle stick, you wash, you assess them, give HIV prophylaxis immediately within 1 hour and no later than 72 hours. And which will check the vaccination status. Take a screenshot of this. That's cirrhosis with ascites and neutrophils. This is SBP treated with antibiotics. That is drug of choice is cefotaxime and albumin. We'll be saying that there's a lot of repetition here, but this repetition is important because these are quite short questions which may come for exam. Hematemesis in a cirrhotic, it's a variceal bleed, with first treated with antibiotics and terlipressin and then do a GI scoping. Painless jaundice with palpable gallbladder, pancreatic head cancer, do an MRCP CT. Fever, jaundice and right upper quadrant pain, cholangitis treated with antibiotics and biliary drainage. Bloody diarrhea and continuous colitis, ulcerative colitis, IV steroids. Fever, non-blanching rash, meningitis, meningococcemia, treated with benzyl penicillin plus transfer to the patient. HIV, low CD4 count, PCP and pneumonia. Fever with West Africa, ring fox, think about malaria, which is Plasmodium falciparum, and treated with IV artesunate. infective endocarditis, do cultures with echo, and watery diarrhea after antibiotics, C. diff, treatment is stopped, antibiotics, and give oral vancomycin. So thank you for your kind attention. These are all the places from where we have, these are all the sources, and the coverage has been done from the blueprint of the MRCP Part 2 written exam, and all these are the places from where these questions have been taken. Again, a quick reminder that the Study Medic is conducting MRCP cases 2 days live on-site program, as well as one-to-one course for personalized one-to-one mentorship. So please contact our team if you have any further details. With this, we would end our today's talk. And if anybody of you has any questions, we'll be more than happy to answer your doubts. And if you have any questions, to all our participants, we are wishing a very, very best of luck for your upcoming MRCP exams, and we hope that you pass with flying colors the examination. We prepare for the cases. So we'll keep another 2 to 5 minutes for any questions if there are any. And you can please type the questions in the chat box. Our team will update us regarding the questions. If something which you have not understood, you can always message us. We will be more than happy to assist you.